no difference in Bmax between the SIADH rats and the DDAX control rats. This slide shows the downregulation of vasopressin B2 receptor messenger RNA expression in the experiment SIADH rats. As shown in this slide, expression of vasopressin B2 receptor messenger RNA promptly reduced, but there is no difference between the two groups. This slide shows the expression of aquaporin messenger RNA expression in the kidney of SIADH rats. As shown on the right, on the left, in the DDAPX rats, expression of aquaporin messenger RNA progressively increased. By contrast, in the SIADH rats, expression of aquaporin messenger RNA was maximal on day 2, followed by gradual decline during the rest of the observation period. Thus, we summarize the data in the experiment SIADH rats. Persistent increase in vasopressin produced downregulation of vasopressin B2 receptor function and B2 receptor messenger RNA. Increased cyclic production produces stereotrofficking of aquaporin 2 and aquaporin 2 protein synthesis, thus increased water reabsorption. Either increased circulatory blood volume or hyposmolarity may ameliorate synthesis of aquaporin 2 in the renal collecting duct cells. This slide shows the 5' region of aquaporin 2 gene. There are cyclic AMP response elements, CRE, and 2 tonicity response enhancer. It means TONI and Newton-E. This slide shows that we make the 1.1 aquaporin construct, and cyclic AMP-induced lac activity in an isotonic condition, but in a hypertonic condition, cyclic-induced lac activity was totally blunted. Similar result obtained in isoosmotic condition with excess urea, in which urea is a membrane permeable solute. This slide showed we studied with dominant negative TONI binding proteins. As shown in the previous slide, cyclic induced lac activity was totally blunted, but when the exposure of cell to dominant negative TONI binding protein, cyclic induced lac activity was restored despite of hyposmolarity. Therefore, hypotonicity reduced the synthesis of aquaporin 2, thus deteriorating the increased water reabsorption. So we summarize the pathogenesis of hyponatremia in SIADH. Increased vasopressin release augmented water permeability in renal collecting ducts, thus producing increased circulatory blood volume and hypotonicity. Increased circulatory blood volume itself causes dilutional hyponatremia. Hypotonicity impaired response of aquaporin 2 to excess vasopressin, thus producing partial diuresis. Increased circulatory blood volume produced secondary change of urinary sodium excretion, thus reduced circulatory blood volume. These alterations result in euboremic hyponatremia in SIADH. Next, I talk about hyperboremic hyponatremia in congestive heart failure. This is edematous disease. This slide shows the distribution of serum sodium levels in patients with heart failure. Georgia, they report here that they showed 19.5% of the patients who had hyponatremia less than 135 millimole per liter. Plasma vasopressin levels markedly elevated in the patient with congestive heart failure. Plasma vasopressin levels gradually increase according to the upper classes of New York Heart Association. This slide shows the correlation of plasma vasopressin levels and cardiac index. Plasma vasopressin levels has negative correlation with cardiac index, which means stroke volume. We demonstrate that aquaporin is excreted into the urine. In upper panel, immunoelectron microscopy using anti-aquaporin antibody shows immunogold particle in 120,000 G pellets of human urine. By contrast, there is no immunogold particle using normal serum. In lower panel, urinary excretion of aquaporin is positive correlation with plasma vasopressin levels in the normal subject. This slide shows urinary excretion of aquaporin in patients with congestive heart failure. As shown in plasma vasopressin, urinary excretion of aquaporin was progressively increased according to the upper classes of New York Heart Association. Again, there is a positive correlation between urinary excretion of aquaporin and plasma vasopressin levels in congestive heart failure. Non-osmotic release of vasopressin is regulated by baroreceptors, which have inhibition on vasopressin release from hypothalamo-neurohypophyseal system. Its afferent pathway is mediated by vagal nerve, nuclear tracts solitarius, and A1 neurons. In congestive heart failure, reduced cardiac output produces reduced effective arterial blood volume. Thus, it makes removal of baroreceptor-mediated tonic inhibition, thus augmenting vasopressin release from hypothalamo-neurohypophyseal system in the congestive heart failure. Georgia reported that predicted event-free rates in the patient with congestive heart failure. Event-free rate of death or heart failure rehospitalization reduced in the hyponatremic subject. Dr. Schreier and Peter Gloss reported SALT-1, SALT-2 study in a hyponatremic subject. Tolvaptan is a vasopressin B2 receptor antagonist, promptly normalized serum sodium levels in a hyponatremic subject, including congestive heart failure. After removal of tolvaptan, serum sodium levels again decreased. This slide shows change in body weight after administration of tolvaptan in a patient with congestive heart failure. Tolvaptan reduced body weight during the hospitalization. The reduction discontinued after the discharge. This slide shows prognostic value of tolvaptan treatment in a patient with congestive heart failure regarding death in hospital, rehospitalization, worsening of heart failure. There was no difference between tolvaptan treatments and placebo groups. This slide shows the Kaplan-Meier analysis of all mortality and cardiovascular mortality or hospitalization during the observation period of 24 months. There was no difference between tolvaptan treatment and placebo groups. However, tolvaptan normalized serum sodium levels during the observation period to 210 days. So, this summarizes the in congestive heart failure disease. Left ventricular dysfunction reduced cardiac output, baroreceptor-mediated activation of vasopressin, renin-angiotensin, aldosterone system, and catecholamines produce water and sodium retention. Increased cardiac preload further deteriorates left ventricular dysfunction. These alterations is ameliorated by vasopressin B2 receptor antagonist. However, left ventricular dysfunction itself remains unchanged in the congestive heart failure. Next, I talk about hypernatremia in association with hypothalamic space-occupying regions. There are three types of hypernatremia. This hypernatremia type B makes reduced circulated blood volume with normal sodium contents. This type B hypernatremia means hemoconcentration and hypovolemic hypernatremia. The electrical disorders of hypothalamic diseases belong to this type B hypernatremia. This slide shows MRI, T1 weighted MRI in the brain. The upper panel in the normal subject. Here is a high signal in posterior pituitary. In the central diabetes insipidus, high signal of posterior pituitary disappeared. This brain CT scan shows hypothalamic tumors. Further examination verified this is a germ cell tumor, and hypothalamic disorders makes central diabetes insipidus and panhypopituitarism. Hypertonic saline test clarified the ability of vasopressin secretion. In upper panel, in the patient with dehydration, there was no response to increasing plasma osmolarity. By contrast, in the patient without dehydration, the response of vasopressin to plasma osmolarity was impaired but remained tertiary. We summarize hypothalamic space-occupying regions. Hypothalamic space-occupying regions produces central diabetes insipidus, hypopituitarism, and disturbance of source center. In the case of hypernatremia with dehydration, the patient suffers from complete type of central diabetes insipidus and adipsia. In the patient with hypernatremia without dehydration, they have incomplete type of central diabetes insipidus, hypodipsia, and keep urinary concentrating ability. Finally, I show you my collaborator to work with me, and thank you for your attention today.
Perhaps I'll start with Professor DeHerder. You talked about the fact